Good news, we have 10 minutes for questions. And then we have a break. If people have questions, please go to the microphones. And I'm going to get started with just one. And I hate to be so global in this question, but it seems to me we have all of you here. And before we let you go, we need sort of some expert thinking, I guess, on, I'm struck by each of you mentioned technology in one way or another. And I'm wondering if you could comment a little bit on what you see the next wave being there. I mean, we hear about it in terms of data gathering, we hear about it in terms of delivery, we hear about it in terms of training. So what's the next frontier there in these different settings, schools, pediatrics? Yeah, Tom.
No, don't want that. So I'd follow I think it's outcome monitoring. Several folks have mentioned that we need to set up systems where the clients themselves can monitor their outcomes. And technology is a great tool for that. What we're trying to do is develop an app so after a clinician does the family checkup, they automatically get set up for the client to be texted once or twice a week with 5 quick questions about how their kids are doing, how the family's doing. That goes back to a website where the clinician can watch the progress in their outcomes, and it's all technologically driven. Something like that is one idea.
And I'll just reiterate what I had mentioned about fidelity ratings. So I think the issue of monitoring fidelity ratings using an automated system and using technology is the way of the future, and it's one of the ways in which we're going to be able to sustain these programs. I also, if I can just have 30 more seconds, I didn't get to my acknowledgement slide, and I just remembered that. So I did want to acknowledge several of the funders, including NIDA, who of course many of their representatives are here, and Hendricks Brown and Jose Shaposnik, and the conference organizers as well. Thank you.
On a more negative note, I know that I talked about parents getting information from text and thinking about smartphones, but in the population that I work with, in Boston Medical Center is a very large safety net hospital. Families, they have a phone number one day, and the next day their minutes are gone and the number is gone. And we did just a medical record search for one phone number, and we found that in 6 months, 25 of our patients had that same phone number. So it really speaks to what happens, and you really can't rely on for direct patient care, particularly with certain populations who have cell phones and then they don't. And then the next time they get money and they put it towards their bill, they get another number. So if anybody wants to tackle AT&T, that would be helpful.
David.
So I was really impressed by Margot and Ellen's presentations about these preventive interventions, family-focused preventive interventions, and the effects of those being done in pediatric practices, and hearing from Willie as well, doing the same thing with older families of older children. And I just, I look at this and I say, you know, we've got the ACA, which is really focusing on prevention. We do have some barriers, like can you charge for group sessions, or does it have to be individual, et cetera? But I wonder the extent to which the American Academy of Pediatrics or somebody might help us develop a business model for pediatric practices, especially since we know that managed care is going to be increasingly where we're going with this, which means bigger practices, which means the potential for doing these kinds of things without taking time away from the pediatrician and the flow of the pediatric services. And yet we can see that the addition of these services, as Margot just pointed out so brilliantly, it's almost like a no-brainer. There's no stigma to being involved in these services, and yet we find all the stigma being involved in a school-based parenting program. Oh, that's only for the parents who need it. But we all think we need parenting assistance from our pediatrician, and the pediatrician doesn't have the time to provide that or necessarily the skills. And yet we see models now of application of evidence-based effective parenting programs, and it just seems to me that somehow we need to develop a business model that shows pediatric practices you can do this, and it's going to build your practice, and it's going to be positive for your practice. And I wonder, that's not the question yet. The question is, so that's the question for the American Academy of Pediatrics. But the question for you all is, can you make the sale to pediatric practices that this is good for your practice? You're going to have more people wanting to be in your practice because you offer these kinds of services, because clearly it's good for the public health. If we could show a business model to pediatric practices that this is a good thing for business, it seems to me that we could quickly change how much of this is available in our country to people who would really want to do it because the pull would be there.
Well, I really endorse that completely, and I would be happy to work with anyone who could help me develop a business model. I would say that when the Commonwealth Fund, under the guidance of Margaret Mahoney, created Healthy Steps, she was very clear she wanted it for everyone. And so, in fact, Healthy Steps started in very wealthy practices and moved to more Medicaid-based practices as we followed the funding streams. But our results are the same. Parents stay. They love their pediatricians. They trust their pediatricians. Even after the program ends at 3, they come back to their pediatrician with behavioral concerns, and they continue to have not a formal but an informal relationship with their Healthy Steps specialists. And we've had a number of practices that have been in operation for over 15 years. So there's legs to it if you can get past the initial sustainability. One other very quick thing for the AAP. Many of our practices say that if they do their scheduling correctly, so they have a Healthy Steps visit, the pediatrician then steps out, he goes and does a very lucrative 5-minute ear check, and then they both come back together for the next Healthy Steps visit. So in fact, there are some practices that would say that they are actually able to see more patients and take on a bigger caseload.
So I, too, would be glad to work with anybody who can create a business model for this, but there are a couple of sort of encouraging things. One is that both the American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry are currently very interested in the development of team-based care. And that's, to me, that's kind of the answer here. So if you imagined pediatric primary care being delivered not by the pediatrician, but by the pediatrician and 1 or 2 or 3, depending on lots of factors, people who each had their own areas of expertise, you would have a built-in system for this kind of thing, the various things we've talked about today, to happen. And I just think it wouldn't, a lot of the disincentives, even to some extent the financial disincentives, would disappear. The only other thing I'd say in response to Margot's point is the problem isn't having parents like it. Parents love it and pediatricians love it. It's really just it's a logistical and financial barrier.
We can hear from the American Academy of Pediatrics.
I would be most happy to respond. And thank you for the question. And Ellen, I think that you answered it. So from our perspective, from the AAP's perspective, we are always looking for the models to make this work. And trust me, we are always looking for the business case to make a point both for getting the services that the children and families need, but also for proper payment for what's provided, particularly from prevention, but also from treatment. And so I think that we have, I won't take too long, but we have such excellent models. We've heard about many of them today. And what we're looking for is how does that work in the context of a medical home or a health home, or name it what you will. But when we're talking in terms of a medical home, we're talking about a family-centered, team-based approach to care. And so what we're teaching, both with the residents and otherwise, is how do you work in teams? And how do you work in the community too? Because we cannot do it alone, nor should we be trying to do it alone. So here are opportunities, and we are spreading the opportunities and the word every single day. But what we're looking for is how do we make it, as you heard so much this morning, how do we really spread and implement it in all the different practices? And that's a little, we're not where we need to be yet with that kind of business model, but we haven't.
Working with CMS to get these kinds of like incredible years in a pediatric clinic supportable by
Sure, we work with CMS all the time. But it's an excellent question. I think what we're looking at is how do you get the proper, we don't even call it reimbursement, the proper payment for what's being done for our partners, but also for the pediatricians. What we'd like to do is to, so I'll go off a little bit on this, because what we'd really like to do is have some CMMI projects that look at the national perspective from a pediatric perspective. But of the 2,000 CMMI, there are more than that now, about 11 of those are pediatric, and we could spend an hour or two talking about that. So if you all can help us work on that, we appreciate it.
Tom.
I'm Tom Boat from Cincinnati. I'm very pleased that there are programs springing up in pediatric settings and that other people are bringing their interventions into pediatric settings. I think the business case is important, but I'd like to talk about another dimension and get some response from our panel. Pediatricians are not so busy that they won't do what's the right thing to do or that's on their agenda. Practitioners in medicine do what they were taught to do for the most part. I mean, that's been shown over and over again. And I don't think we're training people or providing the training context for exposing pediatricians or nurses or social workers or teachers to this kind of thinking and this approach to helping families. I like your comment about that.
I agree 100%. It'd be helpful to start working with associations like the National Association for School Counselors and Social Workers and others to talk about standards of training, because I think in addition to all those are just two niches that I can think of, that these are folks that are standardly in place in context without the tools that they would like to have to work with many of the children and families that they see. So I think training's a key.
So Tom, as you know, I couldn't agree with you more, but there are some changes in pediatric training that are helpful, including the fact that they currently, residents do have a teeny tiny little bit of training in developmental behavioral pediatrics. It should be way more than it is. But I'm old enough to remember when nurse practitioners were sort of invented, and we started thinking about nurse practitioners being helpful allies in pediatric practice, and so now they're totally accepted. And I think at least part of the way that happened is side-by-side training. So I think we need to develop training programs that include pediatricians, social workers, and psychologists that are all learning side by side what it means to collaborate. Because this idea of team-based care, which, as you know already, I completely support, isn't going to happen if the training happens in isolation. It'll happen if we start putting those programs together. So some kind of effort to put postgraduate training together, I think, is at least one way to do it. Pediatric training in itself should also include the notion of preventive mental health and early intervention around mental health issues and developmental issues should certainly be part of regular pediatric training too. But I think putting the training streams together will be a bigger bang for the buck.
We're in a number of residency programs, and South Carolina has just use their McV dollars to put Healthy Steps in all of their medical settings. And as someone who is very involved with the residency program at Children's and at Boston Medical Center, the residents who have Healthy Steps specialists are much more open to learning from them because they're not their preceptors, they're not their attendings, they're not evaluating them. And they also can have more collegial relationships than they might have with their attendings. I have a little bit of data on the impact of Healthy Steps on residency training, but I do think that that notion of side by side, that being in there together, our residents know much more about mental health than they would had they not had somebody who could just naturally infuse it as part and parcel of the well-child visit. So I think that's a great model.
We're going to take one more very quick question because we've already cut into our break time. So, yes, please.
I'm struck. First of all, the panel was fabulous. Everybody gave a great presentation. Thank you so much. In our group, we're always struck at the difference between how evidence-based practices are diffused versus evidence-based programs. So if you're doing social and emotional, it's always a program, but if you're training physicians, it's always a practice. And I'd like to hear the panel's, anybody, whether it's the pediatric group or not, when or if or under what conditions do we try to train practices? And if we were going to go to get pediatricians, as the last question came up, are we going to train them in programs, or are we going to allow them to go with practices in the way that we haven't allowed the social and emotional behavioral intervention field to go?
It's a wonderful question, and one that I feel like I need to think about. I hadn't really thought about them as program versus practice. I know that when people ask me about fidelity, because we don't have the same fidelity standards that some of the other home visiting programs use, it's because I know that our home visitors, our Healthy Steps specialists, are being supervised and scaffolded by the pediatricians. And so I'm wondering whether what we're really doing is implementing a program in which the pediatrician implements the practice. But I need to think more about that. That's a very intriguing question, and has a lot of implications in terms of even thinking about how you market and how you would attract pediatricians.
Tom, Willie, go ahead.
Just for the discussion, I'm an advocate in moving towards practices, principles, and trying to change systems in that model. I think, talking to Dave just before this meeting, I was convinced that, yes, at a certain point in our development as a field, the programs are very, very helpful because we have that kind of investment to make sure they're done with fidelity, and it spurs a lot of research. But eventually, we want the school systems, pediatric systems, to be offering good practices in an integrated way, I think.
And I agree with Tom, actually. I think that was very similar to what I was going to say. And Mary Jane, the same exact question that you asked came up in our group last week when we were meeting with a couple of pediatricians from the medical school, and we were talking about evidence-based program, and they said, we don't need to be trained in an evidence-based program because what we do is practices. And then they kept on talking, and they said, well, these are the folks in our office that do evidence-based programs. And it was, they have a mental health counselor, they have other groups, other individuals that did that. So it's sort of the first time that it came up to me that I started thinking about it. So I think that's a good question.
It might be worth just mentioning that one of the things that might move the field forward then is over time for the nomenclature to actually get a little cleaner so that everybody's talking about the same thing. This is a really helpful discussion. I just want to thank our panel for moving us into these emergent settings and for all the expertise they brought. Before I announce our break, we have, I just want to be sure we mention that all of the slides from the speakers today will be eventually on the website, probably within the next few weeks. So I know some people have been wondering about that. And we have a 5-minute break.